It's a pleasure to see so many of you in here, both in person and joining via the live stream for this important moment in resuscitation science. Today marks the culmination of extensive international collaboration under ILCOR, bringing together the American Heart Association and the European Resuscitation Council to release our updated 2025 guidelines. These guidelines represent not only the latest science, but also the shared mission that unites us to save lives and improve outcomes from cardiac arrest and critical illness worldwide. And it's a great honor to share the stage with my colleague and friend, Federico Semeraro, the president of the European Resuscitation Council.
Thank you, Janet. It's truly inspiring to see the American Heart and ERC representing together today, reflecting years of teamwork within the ILCOR network. Behind these guidelines lies an incredible effort by scientists, educators, clinicians, and volunteers from every region of the world. Together, they have evaluated evidence, debate difficult questions, and ultimately align on recommendations that are practical, inclusive, and based on the best available science. This launch is not only about new guidance, it's about shared vision, collaboration, and the global community of resuscitation.
So what an exciting day for the resuscitation community worldwide. So let me briefly walk you through today's program. First, we'll begin at 1310 with the ILCOR CoSTR and 2025 guidelines overview, where our colleagues will present key updates and the scientific foundation behind the new recommendations. Then starting at 1430, we'll move into the concurrent breakout sessions, where you'll have the opportunity to explore specific topics in more depth, from life support to education, systems of care, and ethics. Finally, we'll reconvene here for the Hot Topics plenary session at 1615, highlighting the innovations and challenges that will shape resuscitation in the coming years. Please remember, all sessions are being live streamed and recorded, ensuring access for our entire international community.
So, as you can see, today's program reflects the full spectrum of resuscitation care. The breakout session covers everything from adult and pediatric life support to neonatal resuscitation, education, system of care, ethics, and special circumstances. This variety captures the heart of ILCOR mission to build continuity across discipline, patient groups, and systems so that every life, everywhere, has the best chance of survival. Whether you are an educator, a clinician, or a researcher, there's something here for each of you, and your engagement will help drive our collective progress forward.
So on behalf of the AHA, thank you for being part of this global effort and for your dedication to improving resuscitation care.
So on behalf of ERC, we look forward to an exciting day of discussion, learning, and collaboration. Together, American Heart, ERC, and ILCOR will continue to advance the science, the education, and the system that save life.
Welcome to the 2025 AHA and ERC guidelines launch.
Welcome to the 2025 American Heart and ERC guideline launch.
Thank you.
Thank you. So it's a real pleasure to leave the stage to Peter and Kate.
Been practicing. No, it's not true. So happy Guidelines Day for everybody. This is a very exciting time for us all. And I do want to make sure that got all my animal slides. Okay. I guess I'll go to my slides then. So I'm starting off this process. These are some of my conflicts of interest. In particular, myself and Kate are now the two co-chairs of ILCOR. So I'd like you to congratulate Kate Berg on her. Partners in crime. I also have some Australian Resuscitation Council and obviously my local intellectual conflicts that I've added. I'm going to very quickly go through some background stuff. And the main reason for that is I think we can't underestimate what goes on behind the scenes, and we must value the enormous amount of work that's been done. So I'll just talk a little bit about ILCOR itself. It really started in 1990 when there was a discussion amongst various guideline writing groups that there was no opportunity to share information. And so as a result of that, really in 1992, after some insight, it was decided that they would create ILCOR itself. And the first approach to publication was in 1997 with some standardised guidelines and flowcharts, which have actually been the basis of everything that we write nowadays. So at the moment, this is the existing spread of ILCOR itself, but we had just our General Assembly, and with the great work that's being done by World Restart a Heart Day, but also our in-hospital cardiac arrest group, the reach is now 192 countries, so that is fantastic. So the ILCOR approach is all based on its vision, and that is to save lives, more lives globally through resuscitation. But to do that, ILCOR has committed itself to evaluate the evidence. And evaluating the evidence allows us to stand up in front of you today and to summarise some of the science, and then you can see the sort of transparent way in which that science is translated into the suggestions that we make. But I'm going to deep dive a little bit into some of the stuff that supports the underlying process. So ILCOR's organisational chart clearly needs to be updated as of half an hour ago. It's Kate Berg. But the member organisations reported there, and then to understand that there are 6 task forces. Now today there are many breakout sessions, more than the number of task forces that we have. So the implication is that the individual guideline body organisations have decided that there are some other bits that they think are really important to put together in a chapter. So you'll have the opportunity to be exposed to that. These task forces, when you go through it, and when we went through 2 days ago, we went around the room and everybody introduced themselves and said where they're from and how long they've been involved. It was absolutely extraordinary. The amount of commitment from people around the world is something we should be proud of. So, since 2017, there's been a yearly publication of all the systematic reviews, scoping reviews, evidence updates that are done within that calendar year. The problem, of course, is there's a bit of a lag. So we are about to submit for posting in December 2025, the publication that will come out in October 2026. So there is this lag, and I'll explain a little bit about why that's important in a minute. But as you can see, up to the 2024 publication there, these are jointly published in Resuscitation and Circulation. And in 2025, we have a total of 172 topics that are being presented. And if you can see the spread amongst the task forces, 33 from BLS, 40 from ALS, 25 from PEDS, 24 from NLS, 30 from EIT, and 20 from first aid. So lots of topics are going to be discussed as part of this 2025 document, which is published as of an hour ago online. So not only the ERC guidelines and the AHA guidelines, but also the CoSTR, and I'll show you what that means, Consensus on Science and Treatment Recommendations. So previously, as of a couple of years ago, and I would argue precipitated or facilitated by COVID, what's happened is journals have accepted that it's quite reasonable to put material that's been submitted for publication into the public domain. So the 2025 documents from a CoSTR point of view, so the ILCOR documents, have actually been at the ilcor.org website since March. And the great thing about that is all the countries around the world that are interested in developing guidelines have access to exactly the same scientific material. And so even though it's formally published today, we've had the opportunity to have this up there in its original submitted form. So that's great. So ilcor.org. Today, of course, the CoSTR is in both resuscitation and circulation. So they might be a bit too close together, but I'm sure that you can work your way around that one. But yes, you can get access to those documents online today. I will refer back to one of those documents. This is the 2 links to the executive summary document which explains a lot about the overarching principles, and then I'll give you a link in a minute to the methodology chapter. So, just a quick summary of the process itself, seeing I didn't start my timer. We do three things, three buckets: systematic reviews, scoping reviews, and evidence updates. In the past, up until about 7 years ago, the only thing we did was systematic reviews. And that's what most people do in the literature. They say, oh, I want to do a systematic review because I want to ask this question. And sometimes the questions are just a waste of time because they won't identify anything that's actually useful. And so you need to actually ask a little bit broader question to get a bit of a feel for what's going on. The first time that we really recognised this was when we were exploring the BLS topic of what about compressions during CPR? And you sort of go, oh, maybe I can do a search looking at doing this sort of compression versus doing this sort of compression. And that was a complete waste of time, as you can imagine. So instead of that, it was looking at, let's have a look at what articles are published with regard to compression depth, compression rate, position of chest compressions, compression ventilation ratio, etc. So we worked our way through and we got a scoping review that actually provided quite a lot of insight and some next steps for that. So I'll talk more about that in a minute. So the systematic review, here I've got cut out of our 2025 document the steps that we use for a systematic review. And I'm not going to, I was going to say not going to waste your time by going through them, but I don't want to underplay those significant steps. We've calculated it's approximately 300 hours of work to create a systematic review. That's a lot of volunteer time. So to do that, it's about creating a question, getting a team, creating a search strategy, making sure that the search has been done appropriately. You then look at the articles you've identified, you pull out the ones that meet your inclusion criteria and exclude the ones that you want to exclude. And then you look at those individual articles and you assess them for their bias or their likelihood of giving you a false result. And in addition to that, we want to extract data which is useful and we put them in a table called a grade table. There are a couple of different things. I'm not going to waste my time or your time talking about grade in great detail, but the use of grade, and I'll put up a slide in a sec, underpins our systematic approach to systematic reviews. So we then create what's called an evidence to decision framework, and I haven't got a separate slide on that, but what that is it forces the task forces to go through a list of questions which include things like, is it really of use? Do people really think that it's useful? Do you think people will accept that? Do you think that there's a significant cost benefit associated with that? And then how do you apply that to different areas? And that's one of the challenges from our point of view. And then we put up our draft recommendations, etc. So the grade process looks at a particular outcome. So if I'm talking about basic life support and compression rate, it's looking about does a different compression rate improve survival to hospital discharge, neurologically intact survival. So for each one of those, it works its way through the evidence available. And that was a transformational thing when grade introduced that process, because otherwise people would say, I've got 3 articles, they're all okay, they look at different things, but I'll just pretend that I add them all together. So it's a much more sophisticated way of doing it. So that's the grade slide. Scoping reviews. This is something that we had introduced, which I again think was quite transformational to ILCOR. So previously we would say, oh my God, as I said with basic life support, that particular question, we can't identify information. And if you can't identify information, you've got 2 choices. You have another go, and then you come up with the same result, and Einstein has a few things to say about that. Or else you actually take a slightly different approach. And the different approach we took was to sort of go, okay, let's have a look at all the sorts of information that's available and see if there are any themes that come out. And then let's explore with a deep dive perhaps some of those individual themes. And that's what the scoping review does. But it also includes grey literature, which is an interesting challenge in itself. In other words, we're not just looking at published articles, we're actually looking at perhaps Google searches or published guidelines or transcripts, etc. I can see a little flag up the back, which I can't read. Data's extracted, but there's no attempt at all to try and make a treatment recommendation about that. All we're doing is summarising literature. So, with regard to a systematic review, we have this sort of approach, but a scoping review doesn't look at bias assessment, it doesn't create grade tables, but it provides a bit of a narrative summary. So if you see a scoping review in the CoSTR document, it'll be just a narrative summary with a suggestion, maybe we can do a detailed systematic review on this particular topic. Is a very different approach. And it ends up with what's called a good practice statement, sometimes. The consensus of science process is a very complex over time. Is that what it says? Over time. Very complex process looking at the number of studies and what the evidence looks like altogether. Then a treatment recommendation, wording of the recommendation is usually strong or weak, and then it's supported by an amount of information that is there. So it may be that there is high, moderate, low, or very low confidence in our estimate. And then the good practice statement is just a statement by the task forces. That's the methodology chapter, but you'll see all that when you go online. And the good practice statements, we follow rules. And the rules are really important. It's not getting together and say, what do you think? It's about, actually, we've had a look at the literature. Doesn't quite give us enough, but putting it all together, we think if we can extrapolate from that, we can get that. And so the end result might be, if IV access cannot be achieved within 2 attempts, it is reasonable to consider IO access as an alternative. Right? So that's what we call a good practice statement. And just to remind you what an evidence update is, basically it's a quick search to just run on a regular basis to see if there's any new information that means that we should spend more time updating our systematic reviews or our scoping reviews. And I hand over to a much more interesting part of the talk.
All right, don't worry, I'm going to catch us up because all of these things that I'm going to talk about you will see later in the day. I'm going to try and give maybe 7 minutes to go through a few highlights from every task force in terms of recommendations. So, basic life support. They looked again at head-up CPR, which is popular in certain areas, but again concluded that really not enough evidence to support use in clinical practice, so really should only be done in the context of research. We did BLS did a scoping review of CPR and resuscitation practices in people with obesity, trying to see if we have any evidence for changing our practice and doing anything differently, and found that we do not have such evidence. And also that the association of obesity with outcome after cardiac arrest is really not clear, and not a lot of data. We looked at defibrillation in women. There are disparities in defibrillation in women with cardiac arrest. Some concern around people not being trained in how to place defibrillator pads around breast tissue or around bras. So BLS addressed that topic. Also looked at locked cabinets for storage of AEDs, for public access AEDs, and advised not locking them because the theft rates are low and locking them doesn't seem to improve that. And it does seem like it probably impedes access for rescuers. And then defibrillator pad placement was a nodal review done with a few of the task forces, but led primarily by BLS, and the main recommendation in adults is anterior lateral placement being preferred. For advanced life support, we did a systematic review of mechanical CPR devices. Those have increased considerably in usage since 2020. And basically concluded that while use is increasing, that's not really supported by data. There's a lot of trials. Overall, the evidence does not suggest that mechanical CPR is better than manual CPR, although we acknowledge the utility in some situations. Also looked at buffering agents in CPR. I think buffering agents have never really been recommended, at least not in recent years, but continue to be used a lot. There are a few RCTs, none showing benefit, so again, this is not suggested. And then IV versus IO access, which Peter showed you an example of a recommendation for. Again, there are now several trials, systematic review in 2025. We continue to say that IV access as your initial strategy is preferred, with IO kind of being if you can't readily get IV access. And then cardiac arrest and hyperkalemia, there's a very exhaustive systematic review done by our group on hyperkalemia, both without cardiac arrest and cardiac arrest in the setting of hyperkalemia. Rather shockingly little data really to support what we do, but a suggestion for insulin and glucose for hyperkalemia and cardiac arrest, and really not enough evidence to support calcium or bicarbonate. Oh, yeah, there was a something accidental lift, and temperature guidelines did not change since a few years ago. Pediatric life support, very extensive reviews on neuroprognostication, and similar to adults, emphasizing that multimodal prognostication. You can't just use one element. You have to use many things to prognosticate. Biomarkers, really not enough data for the pediatric task force to feel like any of them are trustable. And there are some, I'm sure they'll go into this more in the PLS section, but some findings on imaging and EEG and physical exam that might be helpful at specified time points. They also looked at order of resuscitation, so ABC versus CAB, and in the end sort of concluded that, talked about the people being more likely to respond perhaps if they can just start with compressions versus the importance of ventilation, perhaps especially in children, and basically concluded that either approach is reasonable, but that both components, compressions and ventilations, are important. And then blood pressure monitoring, limited data, but they did give some diastolic blood pressure targets for children. Defibrillator pad position, again, that's the same nodal review. So the pediatric task force for children came to a different conclusion of using anterior-posterior placement as the preferred strategy. And then pulse check accuracy, basically saying that if there's an unresponsive child, rescuers should start CPR if that child is not breathing and does not have signs of life, and not to rely on pulse checks. Okay, surging ahead. I know this is a whirlwind. This is just a teaser for today. Neonatal life support, umbilical cord management. So they have done multiple systematic reviews, kind of focusing on, preterm, vigorous preterm, non-vigorous preterm, term babies. So they have had new recommendations kind of every one of the last few years, but recommend deferring cord clamping for at least 60 seconds in vigorous infants, other recommendations for infants in different categories. Also looked at supraglottic airway devices during resuscitation of neonates, and continue to support their use. And I think their recommendation has now expanded to using them during chest compressions. And then for oxygen concentration, I believe this part is not a change, that preterm infants should have resuscitation started with an FiO2 greater than 0.3 or equal to, and term with room air. And then they had a previous recommendation against starting with 100% oxygen, and basically based on a review and identified lack of evidence, they've withdrawn that recommendation. And then video laryngoscopes are now suggested for initial intubation attempts where such resources are available, acknowledging that in many settings they are not. Education, implementation, and teams. So they did a systematic review on debriefing and coaching. These were actually separate reviews, but only observational data, but they showed that both of these interventions do seem to improve some outcomes in terms of guideline adherence, and also in some studies, clinical outcomes. So they recommend both of these things, or suggest. Pre-hospital critical care teams for out-of-hospital cardiac arrest, again, seems to be associated in observational studies with better outcomes, so suggested in settings where these resources are available. CPR feedback devices, actually a lot of RCTs showing improvement in chest compression rate and depth. So there was a strong recommendation for use of these devices in CPR training. And then in situ simulation, simulation-based CPR training also seemed to improve resuscitation performance in a few RCTs. So that is also recommended, again, where available. I think with a lot of ILCOR recommendations, we have to acknowledge that the resources available around the world vary widely, so some leeway in these recommendations. And then last but certainly not least is first aid. So foreign body airway obstruction, no change to the primary recommendation, but I think what's interesting is that they identified a lot of trials and sort of a lot of studies out there on airway clearance devices, and because they didn't really focus on that as much in this review, but they're planning a systematic review specifically on airway clearance devices. And then unintentional injury caused by lay people performing CPR in someone who, it turned out, probably did not have cardiac arrest. There are a few studies. What they estimated of the incidence of injury from CPR in that setting is 0.7%. So the recommendation is, don't worry about it. If you think they might be in cardiac arrest, go for it, do CPR. They also looked at external uterine massage for prevention of postpartum hemorrhage. These studies, I think, it was one trial where they were training women to do self-external uterine massage to try to decrease the risk of postpartum hemorrhage. They did find that more women did it when they were trained. They didn't actually see a difference in bleeding, but I think it seemed a very low risk, potentially beneficial intervention, so was suggested. And then preservation of amputated body parts. Basically, the recommendation after the scoping review is to make an attempt to retrieve the body part, and they give some instructions on how best to preserve it so it can be reimplanted. And I think that is it for your whirlwind tour of recommendation highlights. Now I would like to turn it over to Gavin Perkins and Tina Gray.
So thanks very much, Kate. So my name's Gavin Perkins. I'm the Director of Science and Research for the European Resuscitation Council, and it's fantastic to have the opportunity to address you on behalf of the ERC alongside Tino Gweif, who's our Director of Guidelines and ILCOR. So I'm going to give you a little bit of an overview of the European Resuscitation Guidelines between myself and Tino. And I guess starting really on the primary purpose of the guidelines, the ERC's mission is to preserve human life by making high quality resuscitation available for all. And that's very much been the focus of our guidelines, which draw together the key components of the formula of survival: science, education and implementation, because those are the key ingredients that are going to save more lives. Our guideline process was informed by the Guideline International Network recommendations for producing high quality, reliable guidelines that you can trust. Our guidelines are split across 12 different chapters, covering everything from epidemiology, early life, resuscitation, first aid, education and implementation, mapping across to all of the key elements undertaken by the International Liaison Committee resuscitation reviews. The left-hand side of the slide outlines the stepwise process that we adopted. So starting over 2 years ago, we started to form a steering committee. Throughout the process, diversity and inclusion were a key component championed by the board and championed by Tino as the Director of Guidelines in ILCOR. We were delighted to have the opportunity to work with 141 authors from 31 different countries who made a significant contribution to the guidelines, purposefully selecting people from early career, mid, later career, ensuring that we had multi-professional representation across the health sector: doctors, nurses, paramedics, OTs, physios, and making sure that we brought together those with methodological expertise, those with science expertise, so that we could really produce the highest quality guidelines for you. Our approach is intended to be inclusive. We reached out to the European wider community to both consult on the scope of the guidelines, and then as part of the evaluation process, we put the guidelines up for public comment about 6 months ago and received over 800 comments that allowed us to further iterate the guidelines to make sure that they're fit for purpose. We're hugely indebted to the contributions from 11 survivors and public contributors that have worked and helped us ensure that each of our chapters are relevant to the communities that we serve. Our epidemiology guidelines, we've developed an infographic which I understand is now available online, so please do have a look at our guideline chapters. Each of the chapter has a key message that is based around an infographic. The key messages for epidemiology is really recognising the importance of defining the incidence, the process and the outcomes for cardiac arrest across Europe, because that's absolutely key for driving policy and implementation in order to save more lives. Our focus extends from out of hospital cardiac arrest to in-hospital cardiac arrest and covers all age ranges. It draws on the critical importance of registries, because if you don't measure things, it's not possible to improve, and improvement is very much part and parcel of what we need to be doing in cardiac arrest in order to push the dial forwards and to improve outcomes. We've also focused within that not just the act of resuscitation, but also the legacy of resuscitation for the impacts that it has on both those associated in the resuscitation attempt and also those that survive following a resuscitation attempt, so that there's a focus on making sure that we investigate people comprehensively, to focus that we provide assessment and rehabilitation across the care pathway so that we can really push forward with improving outcomes. Adult basic life support, the focus very much on recognition of cardiac arrest. If you don't recognise cardiac arrest, survival from unwitnessed or unrecognised cardiac arrest is exceptionally poor. It includes guidance on how to recognise and then provide step-by-step instructions about how to perform cardiopulmonary resuscitation and how to use an automated external defibrillator. It goes beyond that to emphasise the critical importance that everybody needs to learn how to do CPR, and everybody should familiarise themselves with how to use an AED and where the nearest AED is, because in the chain of survival, early recognition and activation of emergency services, early CPR and early defibrillation are absolutely key to improving outcomes. Advanced life support builds on the strength of previous guidelines and again emphasises the importance of time-critical interventions. It highlights the importance of starting advanced life support as soon as is practically possible, ensuring that high-quality CPR, which focuses on ensuring high-quality chest compressions but also effective ventilations, are provided for patients unfortunate enough to sustain a cardiac arrest. Defibrillate early, provide vasopressors, specifically adrenaline for people that sustain an arrest with an initially non-shockable rhythm, and focus on early identification of the causes of cardiac arrest so that you can intervene as necessary in the care pathway. Moving to post-resuscitation care, once return of spontaneous circulation is achieved, then a systematic and stepwise process taking us through the ABCDE approach in order to initially assess and stabilise the patient. Then think about specific interventions and the timing of those interventions. So early PCI intervention in patients that have a cardiac arrest caused by an ST elevation MI, or in patients that are unstable following return of spontaneous circulation. The importance of ensuring temperature control and enabling temperatures to be kept below 37.5 Celsius. When it comes to prognosticating, the importance of taking a multimodal approach to prognostication, and that prognostication is focused not only, as we have perhaps traditionally prognosticated for poor outcomes, but also using the tools that are available to us to identify patients that are destined to have a good outcome. Once patients have got through that original critical care journey, then focus on their rehabilitation needs, undertake an assessment that looks at function and develops a rehabilitation pathway so that the outcomes for each survivor of cardiac arrest can be optimised. Special circumstances looks at how we apply the standard advanced life support algorithm in circumstances outside of the ordinary, and the building on the principles of the advanced life support guidelines, but bringing in specific nuances that are relevant for the treatment of specific underlying disorders. And so we present algorithms with specific modifications depending on unusual or special circumstances that have caused a cardiac arrest. Very much a focus again on identifying and treating reversible causes, thinking about those causes across a range of settings, and thinking that if those initial attempts at resuscitation are unsuccessful, what the role of eCPR may play, what's the role of cardiac arrest centres, and how can those all be integrated together in order to provide a joined up systems approach. I'm going to pause at this point, so I'm going to hand over to Tino, who's now going to take us through the remainder of our guidelines. Thank you very much for the opportunity to address you.
Thanks. I'm Tino Greif. I'm the Director of Guidelines for the ERC, and in this function, can I go back? Yeah, this. I'm here to present the other guidelines we produced. This is over there, the slide, because we took the opportunity during this process to make the chain of survival for the ERC in a new fashion. This existed about 20 years, so we now have a kind of modern phone and not the old-fashioned one. Yeah. We summarized the former ring 2 and 3, so basic life support is in the second one. Somebody's bringing now the AED symbol. The third ring summarizes advanced life support and post-resuscitation care in the hospital. And the fourth ring is new because over the time we realized the importance of the survivorship, taking care of these people. So this is the new way we present the chain of survival and give them importance. Gavin presented a lot of adult resuscitation stuff. I have the pleasure to cover all the rest. Ethics, very important chapter, because this is totally new written. They looked at advanced care planning, the guidance for bystanders, hospital personnel. Also a very interesting part about research and ethics for resuscitation, how ethics could be taught, and as always, termination of resuscitation is a very important part. The System Saving Lives chapters is talking about what is needed to make this successful, and this famous saying, you need a system to save a life, is in this chapter. So it starts, as we had it here, with the chain of survival. All the system has to be tailored for the people, so different resources are coming in, bringing the community, start teaching children from kindergarten age on, looking at which resource you are. Even very high income countries have a lot of low resource settings and vice versa. We have to make a proper EMS system. We need to talk to the dispatchers. First responder systems are coming up more and more, and how to integrate these to prevent and make it possible that more people survive. Cardiac arrest centers. Nowadays, so the use of social media, artificial intelligence comes in, and overall a lot stakeholder involvement. If you cannot make this available to hospital administration, politicians, there's no way to get the money to do this. And we have to educate people. In this chapter, we summarized who should be taught, the differences in between, either you're teaching children, lay persons, or hospital healthcare providers, healthcare professionals is the correct word. And now I can breathe. We brought in this chapter modern educational methods in how to teach this, the importance of real feedback devices for chest compression. For the ventilation, the evidence is still not that good to have any idea if this really works. We need to teach the team overall. Debriefing is an important tool to do so. The importance of specific teachings for EMS personnel, either the dispatchers in the office, how to recognize cardiacs, how to deal with the callers, how to instruct them, very important. And then for the courses, how to assess and do faculty development. Neonatal life support, or much better, which I like a lot, the transition to life. Because first you have to live and then you can resuscitate. And then it's also clear where the stuff starts. I learned yesterday. So the first minute, very important. In these first minutes, a lot of decisions have to be made, a lot of treatment. Keep them dry, warm, and stimulate. That's all. Assess breathing, heart rate, and it's so important to open the lungs. So for these very small kids, when they come to us, ventilation's the key issue. And then we look at the heart, how we can do chest compression, special parts always for the very small, for the very early born, and what can be done out of hospital. Even neonatal life support considers a birth at home. This is a low resource setting. So wherever you are. So these are the huge differences they worked out in their chapter and involve the parents. This is obvious. The larger children, again, what I'm proud, the ERC has now BLS algorithms which counts for pediatrics, adults, trained, not trained, all in one algorithm. We don't show it here because then you have to go to the conference. Or to the session. ABC approach, the specific part on advanced life support, again, the team, post-resuscitation care, family-centered approach, a large part about special circumstances and prognostication and the system. This is a huge chapter because for adults we have different guidelines, basic, advanced, post-resuscitation care, special circumstances. They have all in one. Thanks. And finally, first aid. The importance of courses, how to structure these, how to do an assessment for a first responder, for a first aider. Then, very important, only if you can treat life-threatening bleeding, thousands of people can survive better, drowning, and foreign body obstruction, as we saw before. That's all for the moment. But beside of creating these guidelines, we did for this circle a lot of stuff for implementation. So you can find all these guidelines. Now, on the internet, a couple of minutes ago, I got a mail from Jerry Nolan. The guidelines are online, which is good. Beside of this, we created a booklet in lay terms, because I thought all what we are publishing is maybe for us here, but for the people outside of this room, for the politicians, for the hospital administration, for everybody, we need to bring this across in other terms so everybody understands it. We need a brochure, we made a brochure for this, it's freely available also via the web page. And so here you have it, and we made some material for supporting the implementation process. Some pocket cards for the clinicians and some leaflets for the public, for the different chapters. All available there. And finally, we produced an app, the guideline app. This is the QR code, so you can download the guideline. The guideline app will be on function tomorrow after the opening session. Then you have the app and all the material, and the app is then linked to the website, and you can download whatever you want. That's all from my side. Last point, I still have 1 minute and 32 seconds. Amazing. If you know, for the, now a lot of different breakout sessions start. If you really want to learn something, go to a session where you have no clue, because then you will learn a lot. If you go to the session where you're totally in, the only thing is, oh yeah, I knew this already, or I don't know if this is what I'm going to do. So go, for learning purpose, go to something which is totally new. And with this, I will end and hand over about 56 seconds earlier to our EHA colleagues. And Jane will be the next.
Okay, well, we appreciate those 56 seconds for sure. I'm Diane Atkins, and I'm representing the American Heart Association today. Steve Schnecksnyder will also give the highlights. I'm going to talk about the process of how we develop our guidelines. Whoops, hit the wrong button. There we go. Okay, so we actually produce our guidelines in a very similar manner as ILCOR. It starts out with a very structured evidence evaluation for which the Heart Association has hired information specialists so that these searches can be comprehensive. Then there is an analysis, which is really just reviewing the titles and the abstracts to see if the articles that are found by the search are appropriate for the particular question that is being analyzed. Then the literature that is chosen is categorized into yes, it fits the question, or no, it doesn't. And then the final is the scientific review, where all of these articles are thoroughly analyzed, data abstracted, and a final recommendation can be made. How we choose those questions is really very, very important. We start with ILCOR, and we start with the questions that ILCOR has reviewed. And probably ILCOR provides over 50% of the reviews that we need for our guidelines. And so is it an active ILCOR PICO? If it is, then we will use that ILCOR review, either a scoping review or a systematic review, and it can be incorporated into the, or with the working group, which will incorporate it into the guidelines. If, however, there is no active ILCOR PICO, then we submit a request to ILCOR to see if they are willing and able, in the appropriate time frame, to review the question. If the answer is yes, then we will use the resulting scoping review or systematic review. However, if ILCOR is unable to make that review, then the Heart Association goes back to the previous slide on their review process and will review that particular question. Okay. This is not, let's see. Okay. This does appear to be stuck. Let's try this button. No. Okay, so the slides are not moving forward. Can someone, there we go. Okay, so we actually, then the writing groups are tasked with 3 different areas to review. Those that ILCOR produces with a task force systematic review, a scoping review, and we do look at evidence updates, and then the AHA evidence update reviews, and then any methodology reviews that need to be done. Okay, advance the slide, please. Thank you. Now, the Heart Association, because it produces guidelines for many, many subjects that are related to cardiology, not just resuscitation, has developed their own trying to think of the right word, scaling or how we present the guidelines. And first of all, you will notice that in the printed portions, we actually have modular chunks. So if you look at on the table on the left, and it tells you what the question is, recommendation for compression depth and rate. And then we have a class of recommendation in the first column, a level of evidence, and then the specific recommendation. And I will explain class of recommendation and level of evidence in just a minute. And so the recommendation, I'll just take you here through the first one, is during manual CPR, rescuers should perform chest compressions to a depth of at least 2 inches or 5 centimeters for an average adult while avoiding excessive chest compression depths greater than 2.4 inches or 6 centimeters. And then you'll notice that there is a number 1 beside that recommendation. And if you go over to the right column, you'll see recommendation specific supportive text. And that will, in some manner, summarize the discussion and provide the citations for that particular reference. And so if there is a lot of controversy, that is going to be explained in the RSST. And so everything here is presented in this modular knowledge chunk. I'll be very honest, when we first did it, I thought this is not going to work, but I have found that it's very easy to use. I can find things much faster in the document, and I really have thought that it was a major improvement. Next slide, please. So this is our class of recommendation and level of evidence. And this is very similar to the ILCOR, a weak or strong recommendation, and then the certainty of evidence. So a class 1, this is a little bit hard to read, and here I can see it down here. If we say that a class 1, this is a strong recommendation, and the suggested phrases that we use are is recommended, is indicated, should be performed, and we also can use some comparative effective phrases. Class 2 is a moderately strong recommendation, but we divide that into A and B. And A is moderate and B is weak. So these are recommendations that we do make. They are positive recommendations, and we use the words is reasonable, can be useful and effective or beneficial. And the comparative effective phrases are treatment strategy A is probably recommended over treatment B. While class 2B is weaker, and the suggested phrases are may or might be reasonable, might be considered, and usefulness and effectiveness is unknown. Class 3 is no benefit, and generally we require a very high level of evidence to make a class 3 benefit, and that's where the benefit is equivalent to the risk. And then there we also have a class 3 harm that is against the recommendation. So level of evidence is A, B, and C. A is the highest. It's usually a randomized controlled trial or a meta-analysis. B, it's B/R, which means that there is one or more randomized controlled trials, but they're not as high quality as a level A. B is non-randomized, and that's self-evident. C is limited data, and CEO is expert opinion. Next slide. So we had 13 chapters. We also had about 150 authors, and we've listed here the specific chapters that are in the guidelines this year, along with the chair and the vice chair for those. And I think that's, I'm going to hand it over to Steve now, and he will go through the highlights of our guidelines.
Thank you, Diane. Well, to cover really 10 chapters of new content in 10 minutes is fairly tough for a Southern boy trying to get through it, but I'll do my best here. So one of the big changes is a new chapter. In 2015, we had an ethics chapter, but this is really much different than the 2015 ethics chapter. This is a great addition and is a narrative discussion on the foundation of traditional ethics. In addition to traditional ethical frameworks, this looks at really multiple ethical frameworks that are considered important in the literature and by a very talented group of writing group experts to address the inequities and the social determinants of health that are considered very important. Addressing these determinants moves us toward the AHA's goal of eliminating disparities in cardiac arrest, treatment, and emergency cardiac care. Given the complexities of decision-making in resuscitation and the inability of the patient to participate in most circumstances, the chapter explores the ethical challenges across the age spectrum from newborns to geriatric patients. In addition, there are a number of special topics that are considered that deserve ethical reflection, such as organ donation and advanced care planning. And the chapter looks at the effects of resuscitation on patients, families, and the healthcare professional alike. The Systems of Care group that looked at trying to, and really did a yeoman's work in taking a number of chains of survival and combining these into a single chain of survival that takes into account in the hospital and out of hospital resuscitation, and adults and children, and came up with a single chain that goes from recognition and emergency activation all the way through recovery and survivorship. Our neonatal colleagues who have not had a chain in the past came up with a neonatal chain of care, a different term than chain of survival, that goes from actual preventative care before birth and extends into the recovery phase if a newborn does need some advanced care beyond normal newborn care, to try to deliver the best outcomes for newborns. Through their extensive work, there is a new neonatal algorithm as updates to nearly all the algorithms. And a couple of things worth noting with the new neonatal algorithm is for a baby that does not need immediate resuscitation, there's a recommendation for delayed cord clamping now to 60 seconds. And this is going to impact the assessment of oxygen saturation targets. So those are going to need to be assessed at 2 minutes rather than the previous target of assessment at a minute. There's a slight change in the ventilation rate that the lower end is now at 30, so a recommendation for 30 to 60 inflations per minute. And in the unusual event that chest compressions are needed, it's recommended to guide that by electrocardiography, by putting chest leads because that is a superior technique for heart rate assessment. In pediatric basic life support, there are a couple of important changes. One of those is for the child with significant foreign body airway obstruction to have a combination of back blows and abdominal thrust, and this actually lines up with the adult recommendation as well. This also lines up on the back blows with the infant recommendation. Now, back blows are, abdominal thrusts are not recommended for infants. The chest thrusts are recommended for infants. But a major change that's a shift for many years of teaching for us at AHA is the recommendation for chest compressions, and that's to use the heel of one hand or two thumb encircling technique, and to get rid of the two finger technique, because data has shown that two fingers in infants does not produce adequate chest compression, so our educational materials will no longer teach this. Some terminology changes mainly that will clean up some of the things in the educational materials with these changes. Chest compressions will not be used in the foreign body airway materials, but to just keep it consistent and use the term chest thrust. To simplify and be a little clearer on age range, PALS is recommended up to the age of 18, and for clarity on using pediatric basic life support, that pediatric basic life support goes up to the age, not to the age, but to puberty, with a compression ventilation ratio of 15 to 2 to puberty and 30 to 2 post-puberty. But for single rescuers, and this is those compression ventilation ratios are not changes, but if there's a single rescuer, it remains 30 to 2 at any age. And we've gotten rid of in the educational materials, the concept of using the term rescue breaths, just using breaths. In the adult BLS, there's been some standardization in the visuals and verbiage in the new materials for placing the first pad vertically in the right upper chest, when the top of the pad being just under the clavicles. The second pad should be horizontal on the left lateral ribs, and the middle of the pad should be just below the axilla at the mid-axillary line. One of the probably more controversial changes will be in sorry, I got ahead of myself on that one. For adult foreign body airway obstruction, there'll be a recommendation to line up for the back blows along with the abdominal thrust, so that it does line up with pediatrics there. For pediatric advanced life support, a focus for intra-arrest management to maintain, post-arrest management to maintain systolic and mean arterial blood pressures post-arrest at the 10th percentile. This is the higher blood pressure target than previously has been recommended. And there was significant work, as alluded to earlier in the ILCOR presentation, for prognostication post-arrest. It's very important to use a multimodality assessment post-arrest to make prognostication in infants and children, and specifically, as unfortunately too often is done, looking at a single parameter such as cough, gag, or a response to pain at any particular time point may lead to inadequate prediction, whether that's favorable or unfavorable neurologic outcome. EEG for up to 72 hours in combination with other data can give useful prognostic information as well. Now to the potentially controversial one in adults. It looks at the topic that's brought up significant discussion in recent years, and that's double sequential defibrillation as well as vector change for refractory shockable rhythms. And the writing group considered the data and resulted in the recommendation for saying the usefulness has not been established for either one of these techniques based on the currently available data, and that additional questions remain at this point. Just like the pediatric group, the post-cardiac care group recommended maintaining a higher blood pressure post-arrest, with 65 being the target. However, the randomized trials in adults did not show improvement in outcome when they were looking at it, which is a bit different than in children. Special circumstances writing group did a yeoman's work on a number of topics, and I encourage you to take a look at the wide variety of topics that they considered. The two that cross both pediatric and adult lines are hyperkalemia, that was mentioned earlier, and specifically in the face of cardiac arrest, the effectiveness of IV calcium for adults and children for suspected hyperkalemia is not well established. And I think this one will probably be one of the ones that raises a few eyebrows out there. It's not been associated with improved survival or neurologic outcome in either population, and there should be a focus on things that have been, like high-quality CPR, defibrillation, and administration of epinephrine early, particularly in children. For left ventricular assist devices that are more commonly used today than ever, when a patient is unresponsive and has signs of poor perfusion, assessment of whether they are in cardiac arrest is very difficult. And the recommendation is now to begin chest compressions in that instance, and if there's a second rescuer available, to assess the device for signs of device-related reversible causes. LVAD function, because they're not pulsatile devices in most cases, it's very difficult to know if cardiac arrest is truly present. So beginning CPR seems to be very low risk, and the risk for not doing chest compressions compared to device dislodgement certainly points toward doing something in that scenario. And last but certainly not least, we have to get these new concepts out to our training network. But we had a whole education group looking at its own set of issues as well. And that writing group, just a couple of the important things they've recommended for CPR feedback devices, use them in all cases. Improved skill performance is seen, and they're recommended in all skill training, whether it's lay rescuers or healthcare providers. As I started with in talking about ethics, there should be a focus on public awareness campaigns and training availabilities in areas where there are discrepancies, because there are issues with access to CPR education. And children 12 years and older can be taught to perform effective CPR and defibrillation. It can be taught in kids under that under 12, and it's when they're taught emergency response and CPR, it improves their confidence and as well as their willingness to do CPR at older ages. So my partner in crime, Ian Drennan, who was the other senior science editor, will be in the ALS breakout session that will follow this. These are all the concurrent sessions that will be following this session. If you'll refer to your full agenda, it has the room numbers as well as the live stream links. These are the QR codes for the different publications. I think Peter shared the ILCOR CoSTRs for both resuscitation and circulation earlier. This has the AHA guidelines and then the 3 chapters that are published concurrently with the AAP. Those are the pediatric guidelines, and then the ERC guidelines QR codes are there as well. And then the streaming links, and I'll go back to that, the streaming links will be available in the rooms as well. It is 2:07 by my watch. Because of the time frame, we cannot start until 2:30, so you'll have an extra 8 minutes to enjoy tea and coffee at a break, so enjoy the time. Thank you very much for your attention. Could you back it up to the QR codes? It's not backing up for me. Thank you.